Welcome to the webinar, The Emerging Use of Parametric Imaging for Treatment of Critical Ischemia. This program is provided by North American Center for Continuing Medical Education. This webinar is supported by an educational grant from Canon Medical Systems USA Incorporated. I am Dr. Eric Dippel from the Vascular Institute of the Midwest. I am an interventional cardiologist. I have no disclosures regarding this lecture. My goal in speaking today is to discuss the use of parametric imaging and how it's applicable to the treatment of critical ischemia. I'd like to start out by using a phrase that I frequently use to describe the common perception of peripheral arterial disease. If Grandpa walks to the mailbox and has chest pain, we send him to the emergency room. If Grandpa walks to the mailbox and his legs get tired, we say, "You're just getting old." Unfortunately, this is how we've treated this problem for quite some time. The true prevalence of PAD is unknown. In many patients, the disease progression is benign and the majority will remain asymptomatic. Based on epidemiologic studies, it is estimated that more than 10% of the adult population in the United States has symptomatic PAD. This would translate into approximately 30 million people. However, this is probably a gross underestimate. For example, if you look at the Rotterdam study, which is a population-based study done almost 20 years ago on 7,000 patients, the frequency of symptomatic claudication in patients over the age of 55 years old ranged from 1% to over 5% when they are 80 years old. However, if you use ankle brachial index as a threshold for diagnosing PAD, almost 17% of men and 20% of women have PAD. The Partners trial, which was also done approximately 20 years ago, was a multi-sectional cross-sectional study of 350 primary care practices in the United States. Almost 7,000 patients were identified as being at risk for PAD. This was defined as being over the age of 70 years old or between 50 and 69 years old with a history of tobacco use or diabetes. Patients were evaluated by their history and an ankle brachial index, and the presence of PAD was defined by a resting ABI of less than 0.9 or documented in the medical record or a prior history of a peripheral revascularization. When you look at the results of the Partners trial, of these 7,000 patients, 29% or nearly 30% of the patients were identified as having PAD. Again, if you translate this into the U.S. population as a whole, there are millions of patients that have this that are undiagnosed. In the Partners trial, approximately 50% of those patients were asymptomatic or had atypical symptoms, and only a smaller percentage were symptomatic. We know that PAD is an age-related condition. As patients get older in both men and women, the incidence increases. We also know that patients that have PAD have a 3 to 5 times higher mortality rate compared to patients that do not have PAD. Furthermore, patients that have PAD perceive themselves to be ill. If you look at this SF36 Perception of Illness Severity questionnaire, patients that experience intermittent claudication rate themselves as a whole as sicker or more ill than patients that have moderate to severe COPD, and just slightly better than patients that have New York Heart Association Class 3 symptoms of congestive heart failure. We know that the survival of patients decreases considerably the more advanced disease they have. When you look at survival curves of patients that have control versus intermittent claudication versus critical limb ischemia, the survival rates plummet as the disease worsens. To diagnose PAD, we typically use the history and physical exam. Oftentimes, however, patients will have atypical symptoms, leg discomfort, aching, pain, physical exam of palpable pulses. Then we use ancillary testing to confirm our diagnosis. Typically, non-invasive testing, which can be broken down into physiologic testing, such as ankle brachial indices, or tissue perfusion studies, such as a Sensilace test or a TCOM test. Then we have anatomic testing, such as arterial duplex Doppler ultrasound, CT angiograms, or MR angiograms. All of these non-invasive testing is historically done outside of the cath lab setting. We confirm the presence of PAD with angiography and perform endovascular interventions. Ankle brachial index is simply the systolic pressure at the ankle over the systolic pressure of the brachial artery. By definition, the lower limits of normal is a resting ABI of 0.9. The ABI is a good predictor of both non-fatal and fatal cardiovascular events, as well as predicting mortality. A patient with an ABI of 0.5 has a 4 to 5 times greater odds of having an MI, stroke, or death than a patient with an ABI of 1.0. We know that as ABIs decrease, the mortality rate increases. In addition, as the ABIs increase over a threshold of about 1.3 to 1.4, the mortality rate also increases. As patients, for example, have things like diabetes or advanced arterial sclerosis, their arteries can become non-compressible and the ABI is unobtainable. When you look at cumulative patient survival curves, these correlate to baseline ABI scores. As the ABI decreases, patient survival also decreases. Skin perfusion pressure testing is another non-invasive test that can be done in an office setting that looks at tissue level oxygenation. This does have correlation with the degree of wound healing in patients that undergo revascularization. The Rutherford Classification scale is what we use to clinically group patients with PAD. Class 0 is asymptomatic, 1, 2, and 3 are mild, moderate, and severe claudication. And really what we'll be focusing on today is the patients that have critical limb ischemia, which is defined as ischemic rest pain, minor tissue loss, or major tissue loss. Unfortunately, this classification system is non-linear. Patients don't necessarily progress from class 1 to 2 to 3. Sometimes they can present for the first time with class 5 symptoms, but this serves its purpose in evaluating outcomes for patients that undergo interventions. Critical ischemia, as mentioned, is Rutherford class 4, 5, and 6, and usually this is due to multi-level occlusive disease. Due to the collateral circulation that develops, it is unusual that patients have single-level disease that develop critical ischemia. From a clinical definition, CLI is persistent recurring ischemic rest pain requiring opioid analgesics for at least 14 days, ulceration or gangrene of the foot or toes, an ankle brachial index of less than 0.4, toe pressure of less than 30 millimeters of mercury, systolic ankle pressure of less than 50 millimeters of mercury, flat pulse volume waveforms, or absent pedal pulses. We know that CLI has a high mortality rate. This is often underperceived by patients. Frequently, if you tell a patient they have some form of cancer, they may become quite emotional and think they are going to die soon. However, if you tell a patient they have advanced PAD or CLI, they may not recognize the severity of their prognosis. But CLI patients have a mortality rate at 5 years that is on par or worse than many stage 3 and 4 forms of cancer. There are approximately 500 to 1,000 new cases per million people in the United States per year of CLI, which translates into approximately 150 to 300,000 new cases. The rate of non-traumatic amputation is 10 times higher in patients with diabetes than non-diabetics, and more than 60% of all non-traumatic amputations occur in patients with diabetes. Minority groups are more likely to suffer lower limb amputations as well. CLI occurs basically when the blood flow to the affected limb is impaired to such an extent that the nutritive requirements of the tissue cannot be met. The hemodynamic consequences of arterial lesions may be influenced by cardiac output and other physiologic factors, and this is important when we later talk about the parametric imaging because it can be influenced by cardiac output and blood pressure. When you look at the fate of what happens to patients when they have an amputation, 2 to 3 times as many below-the-knee amputees achieve full mobility compared to above-the-knee amputees, and there really has been no significant progress or change over the last 20 years. Rehab can take months to years. By 2 years, only about 30% of the amputees 30% of the amputees are not using their prosthesis, and elderly patients, particularly women and bilateral amputees, have a far worse prognosis. So amputation should really be the far end of the spectrum. This should be absolutely a last resort. We need to aggressively try and salvage limbs. Just the mortality at 30 days for a below-the-knee amputation can exceed 5 to 8% for a below-the-knee amputation, and for an above-the-knee amputation, 8 to 12%. A third of these patients will end up in a nursing home permanently. Only approximately 50% will ever develop any kind of mobility again post-BK, and only about 25% will ever develop any type of mobility post-AKA. 40% of amputees will be dead at 2 years. When you look out to 2 years, again, 40% death rate, and a considerable number, 15%, will have a contralateral amputation. This is a paper published over 10 years ago now, looking at how CLI patients are treated, looking at 417 patients that presented with CLI. Primary amputation rate was a first-line therapy. Only a quarter of those patients had a cardiology consult or a vascular surgery consult, and less than 50% had any type of vascular evaluation before going straight to a major amputation. So what are the treatment goals of CLI? Limb preservation, heal the ulcer, minimize the tissue loss, and avoid major amputation, alleviate ischemic rest pain, improve mobility and quality of life, and reduce cardiac morbidity and mortality. Surgical bypass for CLI is viable. However, it is often associated with prolonged recovery and other complications such as periprocedural death, MI, wound infection rates, vein infections, and still 5 to 10% of those patients still may require major amputation. With endovascular therapy, these patients typically have multiple comorbidities. Endovascular therapy is considerably less invasive with a lower morbidity and mortality than a surgical therapy. We can often recanalize non-bypassable vessels. It is readily repeatable if there is a late failure, and we need not necessarily burn bridges if patients do require bypass surgery down the road. So endovascular therapy has become a first-line treatment strategy for PAD. The role of surgical revascularization is diminishing, and no one should ever have an amputation without some type of vascular evaluation first. With endovascular therapy, there's a 90% technical success rate in revascularizing patients, and 90% of limbs can be salvaged at 6 months with the revascularization procedure. So over the last decade or so, there's been a considerable increase in the incidence of endovascular procedures and concomitantly a decrease in the incidence of major lower extremity amputations. So let's talk about a real-world example. This is a patient that presented to the office who had had ulcers on both lower legs for approximately a year. There was a considerable amount of edema in the legs, but what was also concerning was the eschar that had developed at the base of the right toe approximately 2 weeks ago. On physical exam, the pulses were very weak, monophasic Doppler pulses, and I was suspicious that he probably may have mixed venous and arterial disease. So I got a venous reflux study, which was relatively unremarkable. There was some mild deep venous reflux on the right side and some subsegmental reflux of the right greater saphenous vein below the knee. Both the small saphenous veins were competent. So we did a peripheral angiogram, and this is the runoff pictures. There was a subtotal occlusion at the ostium of the SFA, which then ultimately did fill in via collateral flow, moderate diffuse calcification, but severe distal tibial disease with no significant runoff below the foot, or excuse me, below the ankle. This is digital subtraction imaging injected initially from the common femoral artery. Again, very faint, wispy blood flow below the ankle. The catheter was advanced down to the popliteal artery, and a subselective angiogram is performed, which again provide a little more contrast density, but no significant improvement noted in the blood flow. The proximal perineal artery showed diffuse disease. The anterior tibial artery was totally occluded proximally. The posterior tibial artery is totally occluded proximally. So the question for revascularization is really, what is our strategy going forward here? Do we intervene on the SFA? Do we intervene on the proximal perineal artery or even the distal perineal artery, or try and recanalize the anterior tibial or posterior tibial arteries? I think it's important to understand the vascular anatomy of the foot anytime we're talking about CLI revascularization. It's important to understand the concept of the major blood vessels, the pedal arch, and how they're connected. The angiosomes of the foot are also an important concept to understand. This was developed over 20 years ago by injecting colored latex into cadaver legs and looking at where they direct vascularization went to. And this is important when you're planning your revascularization strategy, of having a understanding of which of the major arteries and branches go to which of the different zones of the foot. There's been a lot of work done on comparing direct revascularization, which is intervening on the arteries going directly to the ulcer bed, versus indirect revascularization, which is intervening on arteries that do not supply directly into the ulcer bed. And whether you're talking about surgical bypass or endovascular procedures, in over 700 limbs studied, patients that have direct revascularization seem to do better than patients with indirect revascularization. This is a paper that was also put forward recently, looking at not just direct revascularization, but the pedal arch and whether it is intact and complete versus an incomplete pedal arch or a completely absent pedal arch, such as these type 3 pedal arches shown on the right. One of the things that was noted in this paper is that predictors of wound healing, obviously diabetes and the presence of infection, are negative predictors of wound healing. But what was also interesting in this paper was that it wasn't necessarily direct or indirect revascularization that predicted wound healing, but the type of pedal arch. And that makes some sense. If you have an indirect revascularization but your pedal arch is completely intact, such as a type 1, then you would expect that through collateral flow you should be able to provide enough blood flow to the ulcer bed. However, if your pedal arch is incomplete, such as type 3, that clearly would be a negative predictor of wound healing. So let's go back to our patient. After we treated the SFA with laser atherectomy and stent placement, we had a nice angiographic result. After we treated the proximal perineal artery with laser atherectomy and drug-eluting stent placement, we had a nice angiographic result. A 1.5 millimeter balloon was advanced as far down into the perineal artery as could be done, and a low pressure inflation was performed. You can see on the right there was some blood now below the ankle, but this gets back to our original question in our final angiogram. We have indirect blood flow to the foot with an incomplete pedal arch, and so what would our next treatment strategy be? Would that include revascularizing the anterior tibial artery, revascularizing the posterior tibial artery, sending the patient back to the wound clinic and hoping that their ulcers will improve, referring them for hyperbaric oxygen therapy, or the biggest problem is that we have no in vivo predictors of wound healing. ABIs, Sensolase, TCOMs, CTs, ultrasounds, all those non-invasive tests are typically done outside the cath lab. When we have a patient that's on the table with CLI and we've revascularized them, currently we have no significant predictors that we can use reliably to say we've adequately done a job, a good enough job to heal that ulcer or not heal that ulcer. So that's where I believe parametric imaging comes in and will become a valuable tool. This is a SFA total occlusion. This is after revascularization. Most people would agree this is an excellent result. But when you look at these images, these are black and white images that rely on a subjective qualitative assessment of blood flow. We currently live in a color world with analytical modeling of most of the decisions that we make nowadays. When you look at parametric imaging, not only can we provide color images, but now we can also provide quantitative assessment of the blood flow. Looking at the red curve before versus the yellow curve after, we can clearly see that we have improved the blood flow. It not only arrives sooner, but has a higher volume and has a higher peak intensity. Now we can begin to provide analytical assessment that is quantitative and objective to determine whether or not that we've provided an adequate amount of blood flow through a region of interest and potentially can predict wound healing. This is what parametric imaging can bring into the cath lab. So parametric imaging looks at time intensity curves of contrast flow through each pixel on each frame of each angiogram. The contrast density is measured and color-coded images are generated, but what's more important now is that you have parameters that can be analyzed in an objective and quantitative way. Things like time to arrival of the contrast, time to the peak of the contrast, which are surrogate measures of upstream inflow, the area under the curve, the peak height of the intensity of the curve are markers of volume of blood flow, and the mean transit time is a surrogate marker of outflow. And so now we can begin to quantitatively assess blood flow into a foot at the time of intervention that can give us measurable parameters to say whether or not we've adequately revascularized a patient. For example, here's a patient that was referred to me from the wound clinic that had an ulcer on their heel. They underwent an angiogram. The images are on the right. Subjectively, the images appear to be normal. When you do quantitative flow curves through the region of interest, The flow curves all appear to be completely normal, so therefore the patient can be referred back to the wound clinic with reasonable certainty that they have normal flow into their foot and the ulcer is non-vascular in nature. Some of the technical considerations to think about with parametric imaging is the before and after images need to absolutely be constant. There cannot be any motion artifact. Digital subtraction imaging is used. You need to have the same source image distance from the image intensifier, the same field of view, the same table height, the same magnification, the same angulation of the camera. There cannot be any compensation filters in the field of view. Vasodilators are recommended to minimize the microvascular resistance. The same injection site, contrast, flow rate, and volume of contrast should be administered and use the same region of interest to interrogate the blood flow. So how do we get from a poster on the wall of the cath lab with angiosome images to real-life patients on the table? This is a patient that was referred for an angiogram that was diabetic, long history of end-stage renal disease on hemodialysis, and had a rapidly progressing ulcer on the right foot with MRSA positive cultures. She was brought into the cath lab for an angiogram, and her runoff appeared to be relatively normal. And so what I did next was selectively inject her tibial arteries to produce these angiosome images. On the left are the traditional DSA images, in the middle are the color-coded images, and on the right side are color angiography images that were obtained. This is a 3-vessel runoff image in an AP projection. This is a 3-vessel runoff image in a lateral projection. This is a selective angiogram in the posterior tibial artery in the lateral projection. Now you can begin to see how the angiosomes of that arterial distribution light up. This is the same artery in an AP projection. This is the anterior tibial artery in a lateral projection. The anterior tibial artery in an AP projection. The perineal artery in a lateral projection. And the perineal artery in an AP projection. Putting those all side by side, here you can see the anterior tibial, perineal, and posterior tibial arteries in a lateral projection, and the same arteries in an AP projection. Let's look at a few more case examples of how this can be utilized. Patient on the images on the left are a patient that had an ulcer just around her ankle. You can see the inflow images on the left. Her arteries are relatively small. She was administered nitroglycerin intraarterially. They look a little bit better on the middle images, but then on the far images on the right, this is after angioplasty to your anterior tibial artery. You can now see how the ulcer begins to light up with the color-coded imaging. This is another patient that had an ulcer on their foot that had what I call relatively slow tibial flow. The runoff images above the knee were all normal, but when you start to look at the tibial runoff below the knee, they were relatively sluggish. This can depend on physiologic factors such as the arterial resistance or even the cardiac output, the blood pressure. The DSA image of the pre-intervention again was relatively sluggish down the anterior tibial artery into the dorsalis pedis. The question was this just simply some vasospasm, or was there diffuse atherosclerotic disease in there? She was administered some intraarterial nitroglycerin. You can see the arteries look a little bit more dilated, but again, still sluggish runoff through the anterior tibial and dorsalis pedis. So, given that she had an ulcer, I decided to put a 2-millimeter balloon into her dorsalis pedis and gently dilate that for several minutes at a low pressure. And again, afterwards, you can see that the runoff looks okay, but these again are qualitative black and white images that are at best difficult to assess. But when you look at the color-coded images now, when you look at the flow curves on the bottom right-hand panel, going from red to yellow to green, you can clearly see that by administering a vasodilator and doing a low-pressure balloon inflation, we significantly improve the quantity and quality of blood flow into her foot that is not necessarily as readily apparent on this plain two-dimensional DSA images. This is another patient that had previously had an ulcer on their lower leg that was treated with laser atherectomy and drug-eluting stent placement. Came back in with a recurrent ulcer, and an angiogram was repeated. This is a 4-year time interval. And you can see the flow curves through the anterior tibial, perineal, and posterior tibial arteries are all completely normal, suggesting no significant hemodynamic difference in flow through any of these vessels. So what we've done is a series of patients to try and define what normal is on patients that have had angiograms that angiographically had a normal appearance. We've measured the time to arrival of the contrast in the anterior tibial and posterior tibial arteries and combined on the far right. And then we've compared that to patients that have had abnormal angiograms that have then undergone an intervention. And what you can see, the time to arrival of the blood into the foot or the inflow into the foot is significantly delayed in the pre-intervention images, and in the post-intervention state, the values are now normalized. And so this is the type of quantitative assessment that we can do in the cath lab to try and determine if we have adequately revascularized a patient's foot. This is the peak height of the contrast. Again, you can see it's not quite statistically significant, but I think the numbers are relatively small. but the peak height of the contrast correlates to the volume of blood flow going through that region of interest, and clearly you can see a trend towards normalization following intervention. So finally, this is an interesting case that was referred to me by a local podiatrist. A patient had developed acute pain in their right foot with a dusky color to the third, fourth, and fifth toes. They were brought into the cath lab, and the angiogram demonstrated a relatively short occlusion of the ostium of the SFA. The remainder of the runoff into the foot was relatively normal. The tibial arteries appeared to be relatively unremarkable. The digital subtraction image of the foot shows that both the anterior tibial and posterior tibial artery flow is open, but relatively slow with diminished volumes. The panel on the right is probing the ostium of the SFA with a support catheter and a glide wire. What you'll see here is the catheter and the wire drop through the occlusion relatively quickly, which is always quite concerning that this represents fresh thrombus, and I was immediately concerned that there may be some embolization into the foot. The panel on the left shows following intervention to the SFA, but sure enough, there was embolization down into the dorsalis pedis artery. After treating this with aspiration thrombectomy, nitroglycerin, and low-pressure balloon inflations, there was good runoff into the foot. When you look at the quantitative flow curves, you can see comparing the left image and the right image, clearly there is better flow on the right. But what I found in this case in particular that was fascinating is the quantitative curves. The white and yellow lines are the anterior and posterior tibial arteries, respectively, before intervention. What you see with the green curve is the posterior tibial artery post-intervention. Clearly, there is a significant amount of significant improvement in the blood flow into the posterior distribution. But what you see the difference now is these curves are no longer superimposed on each other. The loss of the volume from the red curve is the price that was paid from the small amount of embolization into the foot. So this demonstrates quantitatively not only can we improve blood flow, but the cost that can occur with an embolic event. So in conclusion, the goals of CLI are to improve adequate perfusion to heal an ulcer. Historically, we have had no way of knowing this at the time of the intervention. We simply do not have any imaging devices that can be used during the time of an endovascular procedure to predict wound healing. Non-invasive perfusion assessments such as ABI, sense-lace, or TCOM measurements are typically done off the table in a non-invasive lab, and so they're not practical to use at the time of your procedure. Parametric imaging provides live, near real-time, color-coded quantitative assessment of blood flow. Some of the future directions that I think are need to be defined are what are the normal parameters in patients, standardization of the measurement techniques, dose and type of vasodilator drugs to administer before and after our imaging, where to place the region of interest, the sampling size, and the location. How overall does this correlate with wound healing, and possibly downstream predictors of restenosis, late failure, or long-term success. This concludes our webcast. Thank you for your participation, and now we'll take some questions from the audience. Welcome to the Q&A session. Our first question today is, how important is the ABI in determining the patient's course of treatment? I think the ABIs are a valuable screening tool. If you have questions about whether or not the patients have significant peripheral arterial disease, they can be helpful. They can also be quite helpful following intervention and guiding future therapy and vessel patency. However, the ABIs are not a perfect test. They are prone to some errors, particularly in patients that have non-compressible vessels. You can get falsely elevated readings, and quite frankly, if a patient has an ulcer on their foot, I think probably the best strategy would be go straight to the cath lab and not necessarily waste time getting a non-invasive study on a patient. But I think they can be helpful in managing patient follow-up. We have another question. Why is parametric imaging the preferred methodology for lower extremities? Well, I think right now parametric imaging is an emerging technology. It's very exciting. This is getting in at the ground level of how we can define in a quantitative way blood flow into the foot. The simplest analogy that I have been using is that Google knows what you ate for breakfast and knows what you want to eat for lunch, so why don't we use analytical analysis to correlate that to blood flow rather than using 60-year-old black and white subjective DSA imaging. So I think that parametric imaging can become a very useful tool in patients when you're intervening on them to say that you have done an adequate job of revascularizing them. We can use things like direct revascularization, indirect revascularization, type 1, 2, or 3 pedal arches. But in the end of the day, the patients want to know if they're going to keep their foot or if it's going to be amputated, and so do the wound care doctors, and the other primary care doctors are involved in the patient's care. So I think this is going to be a valuable tool going forward to help really define what we do in the cath lab. And we have another question. What is the most important parameter to consider when treating a patient? I think that means the parameters for parametric imaging. We're still trying to define what normal is with the parametric imaging, so I'm not sure if we know what the most important one is. I know that the time to arrival, the TTA, is been highly statistically significant after we've done interventions. Some of the other parameters we're looking at statistically to try and determine where their value lies, but physiologically they all have a different meaning. The time to arrival and time to peak parameters correlate more with the inflow, whereas the peak height and area under curve translate more into the volume of blood flow, and then the mean transit time is more the outflow. So they all have a different physiologic meaning. This concludes the Q&A. Thank you for joining us. Please make sure to complete the post-test and evaluation on the program page that you will be redirected to in a moment to claim your credit.